Welcome to the No Plateau podcast for stroke and brain injury survivors, their caregivers, and the therapists helping them to break boundaries in their recovery journey. Hosted by Henry Hoffman, a certified occupational and clinical therapist, and Pete Duran, a certified podcast host, CPH. Look it up. This podcast is intended to supplement stroke and brain injury survivors' recovery journey. Therefore, all content affiliated with this podcast is for informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment.
It is a big countdown. Hey, everybody. Welcome to another episode of the No Plateau podcast. I am one of your hosts, Pete Duran, Henry Hoffman, who are our stable and neuro expert host is on the line as well with us. Henry, how are you today?
I hope I'm not unstable. That'd be pretty scary.
Stable or unstable? Either one. Let's hope you're a little more stable.
Yeah, I'm doing
good. We are joined today by Christopher Gaskins, who is, by the way, one of the more highly educated folks we've had in the program. He's a Gamecock. He's a turtle. He's got an undergrad in kinesiology and exercise science, a master of science in occupational therapy, and a PhD in neuroscience and cognitive science.
Well, almost PhD.
Almost
in the
PhD.
Final
Oh, yeah,
months.
you're right. This year you finished it up. Boy, how's that going? How's that dissertation going?
It's busy. It's busy. Currently writing and analyzing as we speak.
Good for you. So when we first met Christopher, fascinated by his background, he's a like-minded person. And Henry has a story about Christopher's hometown he wants to start with.
Well, first, I want to congratulate you on sporting a wonderful beard there. I like that.
Thank you.
Keep it going. Keep it going.
Will do.
I usually do that on No Shave November, so we'll see. My family hates it, but we'll see what happens this November. So when we were doing a pre-show talk, Chris, you mentioned you were from Lake City, South Carolina, and you were kind of surprised when you said, "Hey, I know that town, right?"
Very surprised.
It's I had to look it up. It's about 6,000 people live there. It's in central, for the folks, it's central South Carolina. Definitely rural, right?
Yeah.
A lot of farms.
Yeah, yep.
The reason why I know it so well was last year when my daughter was in 7th grade, they had a tournament in the Lake City, quote unquote, country club.
Mm-hmm.
So we all went down there. It was for her varsity golf. We all went down there, or up there, and it was raining. And I was in a golf cart. And if you know some of these municipal courses, it's pretty flat. And then you got trees and you can kind of cross fairways. So as I'm zipping through the golf cart, because it was raining, I was trying to get everyone their rain jackets as they were getting pretty wet. I'm zipping from across hole number 1 to hole number, at that point, it's 2 or 3. Mm-hmm. At the very last minute, I see a gully, like a valley, and it was almost too late. It was actually too late. I had to quickly turn the golf cart, put the brakes on. I was going backwards, and the whole golf cart went back. And as it was going back, I was definitely seeing my life before my eyes. And I was thinking about some of my patients who have had brain injuries. I'm thinking, this is it. This is the moment. This is the exact moment. Well, thankfully, God was there for me. And when I crashed, it was kind of like a vertical. I wish I had the picture. It's a vertical position of the golf cart, and I didn't have a head injury, thank God. So last week, I had the pleasure of going back to Lake City for the annual tournament. And of course, everyone's like, don't get the golf cart, because now I'm known there. I'm pretty popular. I actually do autographs at the pro shop. So I said, there's no way I am getting a darn golf cart. And of course, it was a beautiful day. Had a great time. Sarah tied for second, had a 39. So,
Awesome.
So I went from I can't stand Lake City to I absolutely love Lake City. I got a new fan base there. Sarah did well, and it was beautiful. So driving through Lake City, by the way, is absolutely gorgeous, going from Charleston to Lake City. So if anyone has the opportunity to go to Central South Carolina, that's where you want to be. So that's my story.
Definitely. Make sure you get some good barbecue down there while you're there.
They're famous probably for their barbecue, right?
I have to give you some recommendations afterwards.
Well, if I get the chance next year, I'll definitely hook you up for that one.
Sounds good.
So, Christopher, once again, thanks for joining us. I think with your background, we could go a lot of different places. But one of the first things that I'd like to do is help us understand what made you fall in love with the neurosciences and your affinity towards helping people with stroke. How did that all come about?
Yeah. Well, actually, my senior year at University of South Carolina, I started doing an internship at a pretty prominent rehabilitation hospital. And there I was exposed to OT and PT. And there I had some exposure to stroke survivors. But then I moved to Texas and I transferred my job to that same hospital, but just different location out in Texas. And then there, it wasn't as good of an experience working as a rehabilitation tech, whereas unfortunately, OTs and PTs, they weren't always the most supportive. And a lot of times they would just, quote unquote, give me what they deem to be the hard patients. But these tended to be the individuals that had strokes and brain injuries. And somehow, some way, I didn't know anything about really OT significantly at that time, but I was able to get them to engage and able to get function out of them. And then from there, I started reading books on stroke and just became really interested in how dynamic the condition can be. And that's really what created my interest. And then from there, I went to, Howard University, where I got my OT degree. And then I went on to work at Walter Reed National Military Medical Center, my dream job. I miss it often. Mm-hmm. But during my time there, that's what I did. I really helped kind of revitalize the neuro outpatient OT program as well as the stroke program. And I just really, really fell in love with working with those individuals.
When you think about your time at Walter Reed, what was it about it that still resonates with you so much?
Yeah, great question. So the vigor and the determination and the discipline of the wounded warriors and that ethos carried on to their family members as well. I had the opportunity to treat them, working with the veterans, but then also my chief, my supervisors, specifically Colonel St. Laurent, is definitely an advocate for the profession, but more importantly, he's an advocate for the patients. And, whatever he felt needed to be done for the patients, it was done. And so he gave me the freedom to be able to, research different products to see what would benefit clients. Have various vendors come in and we, try these devices, try different programs. And it just really gave me the freedom to kind of explore neuro rehab. And yeah, from being able to do community outings with my clients, take them to the grocery store and, restaurants and parks to, being able to do the, latest cutting edge robotic technology or even VR, there's just no limit there. So it was a great experience.
You're the first person we've had on the program that have used the words ethos and vigor in the same sentence.
My mom's an English teacher.
Congratulate her on her thesaurus training for you, because that's excellent. And I think you've hit something that at least I learned when I became new to the stroke world and neuroscience. Both those terms apply so importantly, both as a family member or caregiver, as you described, and the patients, right? So I don't know that people realize the level of effort it takes to recover from a stroke or a brain injury versus, breaking a bone, right? Which is fairly defined. It's a rapid healing process. You can return to normal, but that's not the case. Right. How do you dig into the patient's side, right? Your side, where you can show patience and perseverance with someone who it's going to take a very, very long time to recover? What are the first things you do with a patient when they're trying to grasp what's about to happen? Like, what are they going to go through next? How do you set the stage for a patient and what they should expect? And how do you help them understand the level of perseverance, as you mentioned, grit, and vigor? How do you help them understand that?
Yeah, I mean, first I try to convey like a positive mood to relax them. So often, smile, make direct eye contact, just to kind of create that connection. And then I honestly have a very honest conversation that, that stroke rehab is very challenging. And everything that you do matters, whether it's, if you're dealing with left side neglect, and if that, 2 seconds that you can look at me in the eye, if I'm in your left visual field, how much of a difference that really makes to, being able to, instead of you grabbing your arm, hanging off the wheelchair and just slapping it on your lap, actually use that available movement that you have and actually place it there on your own. So I really get them to focus on that, like the little things and how the little things make such a difference. And I mean, usually that helps. That helps a lot. But then also just giving them, stories of success in the past, work with different individuals. Sure. If I can pair them with another stroke survivor, that's often helpful. But then also just recognizing the small improvements. So one thing I like to do that I've learned over the last couple of years is to take videos or have the caregiver or the client take videos. That way they can see how far they've come. And that tends to be like a great motivator for them and kind of helps them kind of hold that grit and that vigor that we want them to.
That's great.
Chris, that's something I always did too. It's amazing how patients forget how much progress they've made. Yeah. I mean, think of weight loss, right? How many times they take photos each week to see the progress they're making with weight loss?
Yeah.
And with patients, they get so frustrated with their mini setbacks. I don't call them, permanent plateaus. I call them mini setbacks. And they get so frustrated because they think they're not making any more progress. I'm like, look, Bill, let's go back to last September. You couldn't even do this at all. And then they go, oh yeah, you're right. You're right. Yeah, I guess I did make some progress. So you're kind of, it's accountability, right? You're their accountability partner, but it's also showing them that we haven't been doing this for nothing. You're clearly making gains. And I'm sure you have stories. Do you have any clear examples of when you did the video? It was like shock and awe for them as a reminder.
Oh yeah. I show a video all the time when I do different community talks for stroke support groups. But yeah, it was this individual that I worked with, and he had a right CVA, so a good bit of impulsivity, and he really rushed his movements, and we had him attempt to play checkers and move checkers from point A to point B. And it videotaped him, and of course, he was very erratic. He was dropping the checkers before he could even get like a firm grasp. He just wasn't really landing the proper placement at all. And then we took a few minutes and actually engaged in action observation, and actually taught him through, how he should be performing the movement. But then most importantly, also told him, which I think is not emphasized a lot, but the benefit of controlling the breathing, and how that can really have an effect on, kind of getting like that parasympathetic system going, helping the body relax, so that you can make more, better quality movements. And after we did that for a few minutes, he did it again, and he was able to move the checker from point A to point B. And I just showed him the video, and yeah, he was simply amazed. And from there, he always did try to focus on slowing things down, at least thinking things through in his mind before actually doing it. And it was definitely very beneficial.
So, Chris, you touched on two things that the audience, that are the patients and caregivers, should get a little bit more color on: action observation and mental practice. So for the folks at home, what Chris described that worked really well for his patient was, as you try to do a task at home and it's frustrating, you got to take a step back and you have to mentally imagine you doing step by step with that task. So if in your example, the task is to pick up a checker and move it to another location, that's like 12 steps. So you have to break it down very vividly into those 12 steps, and imagine you doing the shoulder movement, the elbow movement, the wrist movement, the finger movement, grasping and then replacing to a new location. And then the action observation is whether you videotape yourself at home doing that task, or your caregiver or loved ones doing that task, or you're watching that task online like a DIY project for YouTube, where you watch someone else doing that task. Those are powerful neuroplastic drivers. And what that does is that primes the brain so you can improve and perform better. And that's exactly what Chris's patient went through. So that's awesome. Yeah. And that's the difference between, in my opinion, a neurotherapist that gets it, and just a general therapist that happens to treat a couple stroke patients. So it sounds like your whole caseload is mostly neuro. Is that correct?
Yes.
Okay. So you're a neurotherapist that gets it. And so my frustration, and I can't wait to hear what your thoughts on this, since you're in the weeds with me and Pete. Millions of stroke survivors out there, all going to different clinics throughout the country. We'll keep it in the United States for now. And it's a crapshoot. Who they get, what their background is as a clinician, and what they're going to recommend. Let's just stick to your, metro. What is it like for your patients when they come to you and they've been somewhere else? What stories are you hearing? And maybe it's just me and I'm in a dark little world in Charleston, South Carolina. Or are you also hearing, yeah, my last clinic or my last clinician never once told me how to do X, Y, and Z. Now I come to you and I finally have an idea. I wish I knew this early on. Is that just me in my dark little world, or are you experiencing that as well?
Sometimes, but maybe not as much as you think, because obviously we have the National Rehabilitation Hospital here in D.C. I know Shady Grove Adventist Hospital has a very strong rehab program. So pleasantly, sometimes they have been taken good care of, and they do kind of understand these basic ideas of, quality movement and, spasticity. But then, yes, I do come across some clients that they have had more of a generalist approach as far as their therapy. And yeah, I mean, a lot of times they would have, developed contractures, or, they might not really understand the benefit of a dynamic splint versus like a static splint, which is mainly used for the ortho population. Or oftentimes they've been told that they they've kind of maxed out, they tapped out, and it's the best that they can do. Which I hear that a lot, all too much, and that's unsettling. Yeah, so I mean, I guess in closure, maybe as much as you, just because of this, unique location of having these great, hospitals here and centers here. But I still do
Yep.
hear it. But then one thing I'll note with that is that, with stroke, obviously we know there's the, number one cause of like long-term disability. However, you would think that you will see plenty of neuro clinics, like private clinics, all over the place. Like if you think about PT, you see plenty of orthopedic clinics all over the place, to be able to attend to those people with those needs. But the fact that, stroke, such a problem like in the nation and arguably the world, costs, the hospital system so much money, it causes people so much impairment. You would think there would be more specialists. So although you do have these great institutions that have more decentralized neuro rehab care, you don't see like a lot of independent companies that are able to treat these stroke survivors. So a lot of times they might be able to go to these great facilities, but they're still maybe not quite getting as much therapy as they want, or they eventually go through periods where they're not getting any rehab at all and they're just at home.
Christopher, since Walter Reed, you've ventured into, numerous different paths. In addition to going back to school, you're both teaching, you're also doing research, but you've got two primary initiatives that I want to drill into a bit. The first is GoTHERAPY, and then we'll talk about NeuroSuite after that. So help us understand how what triggered the founding of GoTHERAPY. How did you find this audience that was being underserved? And you've been doing it for almost 6 years now. Tell us how fulfilling it's been.
Yeah, it's been very fulfilling. Well, my co-founder, Robin Baker, also a Howard alum in the OT program, she'd already been doing the work, probably back around 2014, 15, 16, with working with, providing therapy in, more disadvantaged areas, such as the Caribbean or even, Western Africa, specifically Ghana. So she already been doing the work, and she had this idea of, creating a nonprofit that would be able to provide rehabilitation access to specifically the sub-Saharan area in Africa, again, primarily with the focus on Ghana. And she approached me, and I said, sure. I didn't really hesitate because at the same time, ironically, I also had this interest, and I actually was trying to establish contacts with some occupational therapists in Ghana that she just by chance knew. So we linked up, and we worked at Walter Reed together. We brought on our other colleague, Willie Haynes, who also worked at Walter Reed, the three of us. And and in 2017, we kind of surprised our supervisors at Walter Reed. We're like, oh yeah, I'm going to Ghana. And then our supervisor was like, oh, okay, you're going to Ghana. Well, wait, Willie's going too. And oh, Robert's going too. So yeah, all three of us we went to Ghana, and we worked I think we're there for 2 weeks. And we worked at Cape Coast Teaching Hospital in Cape Coast, Ghana. And then also we spent some time creating partnerships and relationships in Accra, which is the capital of Ghana. And that was a very amazing experience where we learned a lot and made some great networking and collaborations. And then from there, I think within that next year, we were able to start what we call the Stroke Community Reintegration Program, or SCRIP. In which this program was focused on being able to pair members of the community in Dodowa, which is in Ghana, and be able to pair these individuals with not just therapists, but also nursing and doctors, just to be able to provide rehabilitation care, but also education. So we really went in with the idea of, providing rehab, but we realized it was a much broader need of just basic health management. In which, blood pressure even was such a huge thing. So I think like within our first 2 years, there were several even people that participated in our program that once we checked their blood pressure, it was so high, we had to immediately send them to the doctor, to be able to get care. So we really kind of realized like the bigger purpose. That started in 2018. And I was very involved in 2018 and 2019. Although my co-founder Robin was actually there, in the community. I was here in the U.S., about providing more remote support by helping develop documentation, help analyze the data, so on and so forth. And the program has continued on, and it's now, completely sustainable. The goal was always for us not to just be able to physically, serve that community, but develop, the idea of autonomy where the therapists and healthcare professionals within that community can be able to continue the program on their own. So
one follow-up on
yeah.
the GoTHERAPY before you go on to your next venture. What's the OT chapter like in that region? I mean, how many OTs are there in Ghana, and what is that like compared to what you know in America? How different is it?
Well, I do know, and we were there in 2017. I believe the first graduating OT class from the University of Ghana, they just completed their classwork. And I think they're out on the field work, but they were just kind of entering, the environment at that time. So OT is.
How many were there in the graduating class? Do you remember?
I don't quite remember. It was probably somewhere between 10 and 20. Probably need to fact check that.
Great.
But yeah, it was definitely a beginning group. So OT, I guess, in some sense, has been in its infancy there, but definitely has grown over the years. University of Ghana has definitely been, a great facilitator of that.
Well, we do. Before you continue on with your second venture, we do a lot of work at Sabo offering hardship equipment to other countries. So keep us in mind on especially stroke. Obviously, that's our sweet spot. We can do some care packages to the therapists there that are working with the patients. Absolutely, 100%.
And by the way, that's, first of all, it's a wonderful cause, and I think that would almost be a podcast in and of itself, right? As you mentioned, when you got down there, the underlying health conditions and environment create so much of this, and I'm sure educating someone after they've had a stroke is very difficult.
Yeah.
But trying to help them understand what the leading indicators and the signs are important. So this led to your new venture, which I don't know many people that launch a business while they're doing all this work and in grad school, but knock yourself out, you're doing it. So, NeuroSuite, what's the main purpose behind kind of your main business? Who do you serve? Why did you start it? Was there a particular audience that you felt wasn't being addressed that drove you to do this?
Yeah, like I mentioned earlier, how, we can easily find like an orthopedic clinic or a pediatric clinic. Despite the severity of, functional impairment from these neurological diseases, you don't see a lot of specialized private clinics serving this population. So that's why NeuroSuite was created, just to really serve the individuals that have neurological dysfunction, ranging from stroke, Parkinson's, multiple sclerosis, you name it. And then in the time of COVID, the idea to be a mobile outpatient service. And then we want to, avoid the need to have to get up and travel to actual brick and mortar locations. That can be physically, mentally taxing. But let's come to your home, your therapeutic environment, and do the work there. So that's really why it was created. And we really focus on providing quality neurorehabilitation and education, as well as consultation, and then hopefully one day research.
Have you found similarities between the conditions you just described, MS, Parkinson's, stroke? Are there parts of your training and background that you're able to leverage across all three? And what are the biggest differentiators between those three different conditions?
I think somewhat, but things are different. So, for example, somebody living with Parkinson's, a lot of times they seem to really benefit from, movements with, large amplitude. Everything is big. It seems to kind of reset, kind of like their motor pattern from these very small, very tiny, low amplitude movements. And they also seem to really benefit from rhythm, or just focusing on like a beat, like whether that's using like a metronome or music, or just helping them reestablish a cadence. Whereas like a stroke survivor, I mean, the main culprit there might be spasticity. So there's a different like approach there. And you might see some similarities there with somebody with a traumatic brain injury. With somebody with TBI, you might have more behavioral challenges, or, just things differ. So, I mean, there are some similarities, but there are a lot of distinct differences. And you want to approach those individuals differently.
Yeah, well, certainly, obviously, the prognosis for those three situations is very different, right? Some are progressing in the wrong direction. Some are progressing in the right direction, and the mental aspects as well. Henry, one last question before you jump in. When you are treating these people, Christopher, what's the biggest concern you have when you send a stroke survivor home with their caregiver for the first time, right? When they're ready to leave inpatient, coming to outpatient, and they come to see you, how much time do you spend with the caregiver coordinating therapy at home? Or is that not something you're very involved with? Kind of describe what that's like.
Yeah, I'm heavily involved. That's actually, one of the big focal points, that I do, is to really immediately be able to establish a communication relationship with the caregiver because I want them extremely involved. I've seen where people that tend to have caregivers or supportive family members, they tend to do better than those that don't. So I guess my biggest thing is the establishment of a home activity program, which I'm really big on within my company because I'm really focused on establishing not just improvement when I'm there, but what are you doing when I'm gone? I often say the most important therapy is not when I'm here, but it's when I'm not here. So how can I change the routine? So these home activity programs, it's often automated. It comes to their patient portal, every day. And they just simply document, if they did the work, or not, or how did they feel? What was the pain? And then also, as I mentioned earlier, upload a video or picture. Let's see how you're doing. And that way it allows the caregiver and, the patient to be engaged in their continual rehabilitation process, but allows me to kind of continuously monitor the situation. And it kind of, helps the caregiver, kind of come into their role of helping the patient kind of reestablish like a routine.
We had Tiffany Top on. She's also a mobile therapist in the Charlotte area. We actually just released that podcast yesterday. It's almost like a concierge service. I mean, what you're describing, you're not going to get that at the local outpatient center where you're going to say, upload me videos. Most clinicians, after work, it's after work, right? It's not going to be upload this, send me that, let me monitor these metrics. So what I'm hearing from Tiffany, what I'm hearing from you, and what I'm hearing from the industry is you have the traditional model, which is you go to the acute hospital, they save your life. You then go to subacute for, 2 weeks, they stabilize you, and then you're either going to long-term care, home health, or outpatient, and then you're in the system. And then what we're realizing through insurance limitations is your system is short. And then after that, you're on your own. You Google everything. If they're lucky, they find you. And if they do find you, great news, you're going to get a level of care that's unmatched to the traditional model. There's just not enough Chris's and Tiffany's, right? So describe to the audience, because there are pros and cons, but from your perspective, do you find it beneficial to visit people in their home environment? Do you think that drives better neuroplasticity than them coming to the clinic to do evidence-based practice? Do you think there's a difference? And if you do think so, if you can kind of explain that a little bit.
I definitely would think so. Yeah, because I feel like we're able to kind of target, that neuroplastic principle, like of, specificity. Like if we're at a brick and mortar clinic away from your home, I mean, moving this block from point A to point B and moving this cone, that might not really connect with you as much. But sure, now I'm giving you your favorite mug that you like to drink your coffee out of every morning, and working on bringing that to your mouth, or, working on, you being able to go outside and sit on your, porch. Now things are like a lot more specific and a lot more meaningful and salient to the person. So yeah, I would argue that just based off of those principles, things are possibly driving neuroplasticity a little bit more.
Yeah, I agree 100%, by the way. I think it's all about salience and it's all about function. And it's hard to replicate that in a clinic. Of course, the clinic's traditional model, and we all had great outcomes in clinics. I'm not saying everyone burn the clinics and go back home, but I do think there's a little bit of a advantage being in the home environment. Out of curiosity, do you accept patients? Do you bill insurance, or is this fee-based, or how does it work for you?
A hybrid model. So I accept insurance as well as private pay.
Okay. And then typically how long will you see? Another impediment to success with these patients is the frequency and intensity. So if I was lucky enough to be in your neighborhood and have you as a clinician, and I suffered a stroke and I'm, let's say, a chronic stroke survivor, meaning greater than, let's say, 6-9 months, how often would I see you typically, and how long can that last before insurance says enough's enough?
Yeah. Preferably 2 to 3 times a week. Sometimes I may try to do even 3 to 4 times a week. Usually keep that going for usually like a month and a half. And then at that point, we begin to kind of stretch out these sessions where I might not be coming in, 2 to 4 times a week, but it might be, once every couple of weeks. But then we're shifting the focus to more of the home activity program. So although I'm not coming as much, to kind of compensate for that, I want you, to really get down on your P's and Q's and make sure you're doing that activity program consistently, that I'm still able to give you kind of like that feedback, even though I'm not physically there throughout the week.
Yeah. And my last one regarding your mobile therapy and your experience with that specifically is the motivation factor and the compliance. Accountability is very important. They need to be compliant. You've come up with tools to make them compliant. There's a lot of listeners who, are just frustrated. Some of these folks didn't go to the gym before their stroke. So why on earth are they going to start being proactively going to the gym after the stroke, right? Typically, they say you can't change behaviors after the age of 25, 30. So from your experience, how is the compliance problem? How significant is it? And when you do have folks that are pretty darn non-compliant, do you typically lose that battle or can you win them over?
Yeah, that's a great question. That's something I struggle with a lot as a practitioner. But I feel like that's what we need to be trying to do is really change the behavior, the routine to have like a long-lasting success. Honestly, that's something I struggle with a lot. I don't really have like the perfect answer just yet. But I will say it does something though. When I'm doing my reevaluation, I show them this nice little, pie chart, this nice little bar chart here. And I'm like, hey, here's your compliance. It's way down here at 10%. Like every time I see this homework, you're doing it less than 10% of the time. But yet, you still have this pain or you're not able to achieve this goal that you wanted. And sometimes that level of accountability is kind of wakes them up. They, strive to do better. They try to be like a little bit more accountable. And honestly, sometimes they don't. And, I don't know if this is always the right approach for me, but, I fully believe that I will do all I can to help you as a practitioner. But I believe that, yes, you do have to have some accountability and you have to kind of take ownership of, the goals that you want to achieve. So if I do see a continued situation where there's not compliance and we try different things, sometimes it may not be the best fit.
I think when I gave the gym analogy, and then I usually think about exercise in general. And sometimes what stroke survivors don't realize with neuroplasticity is, we talk a lot about the pillars, the main ones, the mental practice, the action observation, the task training, the constraint-induced movement therapy, all the ones that people are familiar with. A lot of folks don't realize the importance of just strength training or exercise training or aerobic training and what that does to the brain. Folks listening, there's a fancy acronym BDNF, brain-derived neurotrophic factors.
Neurotrophic factors, yep.
And when you increase your intensity in an exercise workout, you increase that. And that's a chemical booster to your brain to help preserve them, mature them, and to grow them. And that helps with rewiring. So if you have a hard time being compliant, and there's a lot of good evidence out there on things you need to do, just start with the basics. Get an arm bike.
Yeah.
Start exercising, get a leg bike, and then get that little chart going, 10 minutes, 15 minutes. Because I'll tell you what, I'm the most non-compliant non-stroke survivor. My wife loves going to the gym and she sees me doing 20 minutes and taking like 20 breaks, looking at my phone and just laughs. She even texts me while in the gym saying, nice break. So I have zero BDNF in my cortex. So we need that chemical boost. I know Pete's probably overloaded being a trainer, but stroke survivors, start with the basics. Just start exercising. Forget all the fancy neuro rehab recovery, right? Let's start with the basics.
I have to say, I think about a client I just was working with, just finished working with a couple weeks ago. We started off with our home activity program. And I had CIMT in there, constraint-induced movement therapy, and task, Pacific therapy, had him doing all kinds of things with his woodworkings. That's his hobby. And by the time we were done, I just wanted him to ride a bike. I changed the homework program so much. I said, hey, man, I know you like to ride your bike. Just go around your cul-de-sac a couple times. That's something that you enjoy. That's meaningful to you. That, will bring you out of your negative mood or depression. And also it's that aerobic activity. I agree. Sometimes simplicity is key.
Speaking of aerobic activity, and particularly in exercise in general, as you guys are on this topic, as a trainer, I know how important just physical movement is to all the chemicals it releases in your body. Like you said, emotional, physical, all the aspects. Particularly for a stroke victim, I think what they don't realize, and when we had Guy, one of our I'll call more infamous survivors, and his wife Jane, tremendous caregiver in the program, and this is important. I want to know, and I think you have implemented a bit of a accountability or tracking aspect to your therapy, which I haven't heard other people do. Sometimes just doing the work is the win, right? It doesn't have to be measured in progress. It's just the reps. So what Guy has done, he puts up a chart. And if he just checks off the reps every day and then looks at it at the end of a week and then looks up kind of as Henry said, holy cow, I did this for 7 days. I can move this an inch farther or pick this up a little higher, or I've got a little more strength here. Just doing the work is the win. And sometimes they don't realize that because the progress is so slow. So I think that's where, man, you have a Hershey's Kiss, Hershey's Kiss at the end of the night, or you take a picture and send it to Christopher, your wonderful neuro OT, and say, I did the work this week. That's just the win.
Right.
Knowing that, like you said, big movements or cardiovascular movements are challenging for an early stroke survivor, how do you help them ascertain what they're capable of? And then how do you handle that very delicate, knowing that they've got to push themselves a little bit? That's the challenge, right? You got to get yourself a little uncomfortable. How do you coach them through that, Christopher?
Yeah, a lot of my patients call me a hard charger. Sometimes I might push them a little bit too hard.
Okay.
But yeah, I often feel that, they can do more than what they think they're capable of. But when we push them, that extra, 5-10%, they say they can do it, then that raises that threshold a little bit higher. And you just keep on incrementally pushing them a little bit past what they think they're capable of. And they, are able to continually go further and further. Yeah. So I just really kind of utilize my personality. Like I said, I could be a little bit of a hard charger. I think that probably came from working with the Wounded Warriors at Walter Reed.
Yeah.
But yeah, they just kind of, they're able to kind of keep on going and keep on pushing themselves.
When you think about the stroke survivors you worked with, and this is probably going to be an interesting question considering you worked at Walter Reed, can you share with us the most inspirational survivor you've ever worked with?
Probably the first stroke survivor I worked with when I went down to outpatient, like in at Walter Reed. This was before I got my certified stroke rehabilitation specialist cert. So I don't know. I still was kind of learning and trialing things, and didn't know a whole lot as much as I do now. But yeah, I worked with this individual. I mean, she was barely able to kind of move her limb.
Okay.
Some of that spasticity just kind of begun to emerge, but kind of on the lower level of the Brunstrom stages of motor recovery. But she was a very spiritual woman. So obviously there was an immediate connection there. She just always had a positive attitude. Sometimes she looked at me like I was crazy because I gave her challenging things, but she would still always do it and just always kept a good outlook on things. And she progressed over time. And to the point, I think I worked with her for probably about a year. But the hallmark of that situation is that we literally became like friends. But as she discharged, she always kind of cracked jokes with me about, I claimed I could cook because I'm a Southern boy, but she didn't think I could cook. So we were always kind of, talk about recipes. And she was like, you need to come over here and, you try to make Thanksgiving dinner with my family. So I'm like, all right, I'll do it. So yeah, the two of us, we prepared Thanksgiving dinner for our family. And that was an amazing thing to see her after a year of therapy, being able to engage that arm and that hand in so many different ways, to stir that batter and put things in the oven. And then also I was able to, kind of flex my cooking skills on her also.
Well, you're describing exactly what makes OT special, or any other health professional that really dives deep and immerses themselves in the recovery with their clients. It's unfortunate that there's, like I said earlier, there's not enough Christophers to go around. Mm-hmm. Pete, the last question I had as we wrap up is about the future of stroke rehab. We're talking to a very intelligent licensed practitioner here, so I know we're going to get some good, juicy information maybe. I have ideas. Pete has ideas. We've talked to other guests about their ideas. It's a common question. Where do you envision stroke rehab going? I don't want to say next year, 5 years, 10 years, maybe. What about 20 years? I mean, are we going all digital? I'm not a huge video chat guy. I still like the one-on-one live, especially with physical impairments. So I know we can't go all in on video. And, part of me thinks it's not going to be, if there's going to be a seismic shift in stroke recovery, it's going to happen in the first 6 hours of their event medicinally versus what you or myself or another clinician's doing. But let's assume it's not a medicinal panacea. Okay. What do you think? What's your best hope? 10, 15, 20 years from now with stroke recovery. If we were on a podcast and we're sitting in the rocking chair and we're in Lake City overlooking the country club, having your favorite barbecue, what will stroke rehab be like 20 years from now if we were there?
I definitely would imagine more therapy. The current model, given, insurance allotting 30 days for therapy, a year, that's just not it. It's just not enough. Yeah. So yeah, that's what I would envision. I would envision, especially, as individuals anywhere from, roughly 3 months out from their stroke, just be able to engage in that more intense therapy for longer periods of time. And this idea that, the work is never done. So you might have intense therapy, I don't know, for a month or two at a time. And then you might take a break, but then like we re-engage. 'Cause there's so many clients I've seen that haven't had therapy in years. So kind of keeping that staggered approach I think could be very beneficial. Because as we know, like there's no plateau in sight. Like sure, you can have these, as you say, these micro plateaus, but if I come back and check on you 6 months from now, we might be able to get like a little bit more further. But then also the access to equipment. I would love to see insurance cover the use of TENS or neuromuscular electrical stimulation unit. I mean, I think a lot of evidence has supported that. It's fairly cost effective, but yeah, to be able to see insurance cover that would do a lot and be able to help people. I'm not as optimistic about doing rehab in the context of the virtual environment or via like video, just because a lot of times I guess it depends on the severity of the stroke, but a lot of times those individuals need that contact, that manual contact to properly facilitate or inhibit these different muscle patterns that we just haven't really found out how to replace via like video. So yeah, in closure, that's what I'd imagine. More therapy, especially after those first few months of having their stroke, using a staggered approach, and then more provision of equipment that's shown to drive neuroplasticity.
Well, the best indicator of the future is when you look back to the past. As you were talking, I was thinking about the last 50 years of stroke rehab and how much has changed. Think about the 70s. Well, you can go back to the 50s, 60s, 80s, 90s. I graduated in the mid-90s. It was heavy Bobath.
Oh, yeah.
It was heavy NDT, right? There was no evidence-based practice really for stroke rehab. There was a lot of theory-based principles, PNF, Brenstrom, Bobath, Rude, all those different approaches. We've come a long way, even in the 30 years. And then constraint-induced movement therapy was the first massive breakthrough showing that you can rewire your brain thanks to, previous pioneers like Dr. Merzenich showing that the brain's soft-wired. So yeah, it's going to take a while from a rehab standpoint. I mean, but I got to tell you, the last 10 years, 15 years have been pretty significant when it comes to RCTs showing things that work. We didn't have that in the 80s, 90s.
Yeah.
It was all, let's just do NDT and stretch. Right. You're not going to stretch your way out of recovery. Let's just keep weight bearing and then goodbye. So I'm staying optimistic. I agree with everything you said. And I think access is key, intensity key, but we also need to objectively formalize protocols. And I think we're getting better at that. Where these new grads, there's no more, wishy-washy stroke rehab, do this, do that, and we'll see what works. It's going to be science. Science is going to drive it with the protocols based on your impairment level. So yeah, I'm 100% behind that.
We have to, in closure, I also feel, we have to do the research. I think as a profession, I feel like we need to have more of an intimate kind of connection with data and understand how to harness that data to inform decision-making and extend that to actually policy-making. So I also would like to see, the data that we create with this great research, these RCTs, how we can actually translate that to policy, with what insurance is covering. I think that's key.
Christopher, thanks so much. And I know that, we could talk for days about, what you're learning in your PhD program, what you've learned in GoTHERAPY and the other programs you have in place. But I know when we first met and decided to get you in the program, we need more folks like you out there, right? Just passionate, always learning, and your thoughts about what's needed in the future, couldn't agree more. So thanks for being on the program. Hopefully that whether you're a therapist or a survivor or a caregiver, you learned a few things, and feel free to reach out to Christopher. We'll put his contact information in the show notes, and make sure that you look up his facility and follow what he's doing, because he's going to listen to the future of stroke rehab for sure. So thanks for joining us on the No Plateau podcast, and everyone have a great day.
Thanks, Chris.
Thank you for tuning in to the No Plateau podcast. Please make sure to like and subscribe to stay up to date on more stroke and brain injury recovery stories. The No Plateau podcast is intended to give you an insight into stroke and brain injury survivors' journeys. Any opinions given on this podcast are strictly the individual's, and we do not suggest that you necessarily hold the same viewpoints as anyone on this podcast. This podcast is intended to supplement stroke and brain injury survivors' recovery journey. Therefore, all content affiliated with this podcast is for informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. always seek the advice of your physician or other qualified health providers with any questions you may have regarding a medical condition. Reliance on any information provided by the No Plateau podcast is solely at your own risk.